Hello everyone, we are back in the program. We had like a small break, so fasten your seatbelts, and we are starting with the last keynote for today's part of Data Science Conference Healthcare US 2021. Basically, our next speaker is going to be Dr. Pradeep Goel, who is Chief Executive Officer at Solve.Care Foundation. Basically, what we can say about Pradeep for his entrance, that he is a healthcare executive with a relentless focus on improving administration, coordination, quality, and efficiency of care. He has 25 years of healthcare experience, CEO, COO, CEO, and CTO insurance, benefit administration, and public programs. And what we can also say that he's proud father of an amazing talented daughter and hurricane son. In addition to that, we also said that he's a part of, he's CEO of Solve.Care. And just like for the introduction, Solve.Care is a global healthcare blockchain technology company, which is using innovative approach. They are tirelessly work to solve the complex problems that plague healthcare around the world. Without further ado, I would like to give the mic to the Pradeep. And Pradeep, you can start with your presentation. I will just go mute myself and stop video, and we will be there if anything needed to be done. Thank you so much.
Thank you very much for having me, and it is an honor and a pleasure to speak to all of you today. Solve.Care is a very interesting company that I am involved with and proud to be part of. And having spent about 30 years in healthcare administration in various roles, I like to say that we are actually trying to solve the problems that I, in my previous role as CIO or CTO or CEO, struggled to find solutions for. I'm happy to share this deck with you today with the hope that this will stir ideas and thoughts on how we might approach a better way of delivering care to humanity, a more equitable, more efficient, and more effective way of doing things. So let's get started. Many of you who are involved in healthcare have heard this again and again, but those of you are looking at healthcare more as a participant, if you are part of any health policy discussion, you will always find these statements made at the beginning of almost every presentation. We have to find ways to deliver better health for the population we are serving, be it insured population or a Medicare or Medicaid population or a population of patients that a hospital or a hospital system serves. We have to assure better health for those people who rely upon us to deliver better care. And we have to be able to do that in a manner where we deliver the most optimal care at the highest value. These are typically the triple aim, and there is sometimes talked about the quadruple aim, where we also talk about the patient and private provider experience. Now, this slide is not from the US, it's actually from a ministry in the Middle East, the Saudi Arabian government. They published this plan or their vision. And you will find a similar vision in every country, whether you look at Qatar or India or Pakistan or Canada, you will find that these are always stated as the goals. And I put this up here because I want you to understand that our vision for healthcare equity and equanimity is not just a US phenomena. Every society in the world wants the same thing. This is the second thing that you will hear. Let's put the patient in the middle. Let's make sure that all of us act as a team around the patient. Patient-centric care, patient-centered medical homes, building a care model where the patient is empowered to make decisions. We want to give the patient better choice. When you think about the initiatives like the Affordable Care Act, or before that, the Health Information Portability and Accountability Act, or the Health Savings Account projects, all of these sought to do the same thing, give the patient the ability to be an involved, engaged participant. That's the goal. But the truth is not the slide. The truth looks a little bit different. This is how the truth looks like. The patient is a participant, a beneficiary, a receiver of care, a receiver of benefits. And we often, as organizations, including the ones I used to represent in various C capacities, insurance companies, TPAs, Medicare, Medicaid agencies, hospital systems, all of us choose to interact with each other where we treat the patient as a consumer, not a participant, whom we deliver services or benefits to. And oftentimes a patient has no information or data. nor do they participate in our system-to-system interoperability conversation, nor do they really have the ability to consent to the use of their data, despite what HIPAA says. And for sure, the patient isn't involved in any kind of a transactional capability, and their identity is typically managed by us, not by them. And payment responsibility also often is third party. So we talk about patient-centric care, and we deliver patient exclusionary care is what we actually do. And I think that therein lies the fundamental issue that we both ethically and technologically have failed to answer for the last half a century, which is how do we really empower the patient-doctor interaction to be better? So Solve.Care's vision and mission is to rethink that relationship. And we started to ask this question not recently, but 10, 20 years ago, when I was building very complex eligibility, enrollment, member management, care management, disease management, claims adjudication and payment, revenue cycle management systems. And I realized back then incrementally and increasingly that if you're going to ever build a network coordinated patient-centric model, you're going to have to step outside this architectural paradigm that has taken over most of healthcare, not just in the US, but around the world. And that we are going to have to build network health applications where a patient can participate, where they do have a role and a say in the actual transaction. They actually participate in the business logic, where they actually manage their identity and they have the ability to give consents, and that there is some ownership of data. Custody of the data should not make me owners of the patient data, but rather simply a custodian. And that in communication and coordination, I have to facilitate secure and trusted communication between parties. All of these things, the current architecture of system that I proudly built for the last 30 years does not support. So we need to think another way, because we cannot achieve what our systems will not permit. So we need to think differently about relationship management. We got to think about what is really important. And if you really think about the most important relationship in healthcare, it's the patient-doctor relationship, not rocket science. You can understand the view that the most important relationship in all healthcare delivery is a conversation between patient and doctor. And if we streamline that conversation, where we facilitate, empower, encourage, and enable that conversation to be more effective, then everything flows from there. Yes, there are other conversations that need to happen: the patient-payer relationship, the doctor-payer relationship, the doctor-specialty relationship, the patient-specialty relationship. There are dozens more. So if you were to stop thinking of healthcare as a process and start thinking of healthcare as a relationship management problem, things get very interesting. You can start to actually solve the systemic and endemic issues of why we haven't been able to fix healthcare in a manner that we claim that we are working so hard to, and yet we never seem to make any meaningful progress. And that is the premise on which I want to base the rest of my presentation, that let's think about healthcare in the context of relationships. I will give you an anecdote which will help you illustrate what I mean by relationship management versus process management. At Blue Cross, I had a design room, and I had my various vice presidents come out to the design room. We had no chairs. You had all the walls that could be written upon, and you could walk around and you could draw on the whiteboards or on the walls and essentially try to simplify complex processes like enrollment, eligibility, adjudication, whatever. And one time, one of my vice presidents brought to me the process of enrolling a new member, and she papered the whole room end to end. It was a 60 feet long process. And then she would trace along the wall, walk me along the wall, and point out the step in the process that needed to be changed if we wanted to enroll members differently or more efficiently. And these are the pre-ACA days when we were trying to rethink how we're going to enroll members directly on the exchanges. And I understood that to make any change in the 60-foot long process is going to require millions of dollars. And it really befuddled me that we could not simply adjust anything in any processes because of the way systems are architected. But end of the day, if we were to rethink that business process as a 60-foot long printed process coded over the course of 20, 30 years into actually an ABC triangle, where the patient is the A, the doctor is the B, the payer is the C, and we only focus on A, B, B, C, or C, A relationship at a time, we could do this so much easier. So this long process could actually become a very, very small, tight circle of 3 relationships governing everything. And that is the inspiration behind a relationship management system for Solve.Care that Solve.Care is building for healthcare. So think of it as Salesforce.com type of a system built for healthcare, where relationships are easy to configure, easy to manage, easy to modify, easy to audit, and not have this cascading impact on every other business process that we are doing, which leads to enormous cost and inefficiency of healthcare that we see, whether you're an insurer or a hospital system, whether you're using Epic or Cerner or McKesson for EMR, or you're using TriZeta for adjudication, problem is the same. These are inflexible systems that claim to do everything, don't do most anything well, and we are required to live by their rules, and modifying them is typically a career bet for the CIO. That shouldn't be the case. So what we decided to rethink is to build a healthcare application platform where secure network applications can be designed and published in minutes and hours or days, not weeks and months and years. And every relationship can be configured quickly, whether it's the application experience or the business logic or the data custody or the security and privacy or the consents around use of data, 100% auditable, and on some kind of a shared fabric where I don't have to buy my own big data center to run an eligibility system. And that is the vision and the mission of what we are doing and what I want you to think about. If you use this relationship management system, and you don't have to use ours for sure, but I want you to think about this. If you were to use a relationship management model, you could do clinical management very differently. You wouldn't have to do disease management along the fixed care pathways, but rather you could configure permitted relationships between doctor and patient around each disease condition or each care method or protocol. Care coordination becomes a simple matter of ensuring the right events get from A to B or B to C or C to A or A to C. So it's become very easy. We could start empowering the physician to do things that today we give a lot of lip service to: risk sharing, value-based contracts, pay for performance, provider education and engagement. Those are big fancy words, but they don't really work in the real world because we don't give the physician the flexibility to treat an individual. And individuals aren't statistics. So we build systems for statistics, but reality is physicians serve patients and who are individual human beings with individual needs. So physician efficacy is a function of granularity. Care gaps and care opportunities. You could do the same with administrative processes, completely change the way we enroll or adjudicate or pay or re-verify or do referrals or pre-authorization. And same with financials. You can completely rethink how you do financial models. Let me give you some examples. On our platform, we built a provider reward program, which is essentially a value-based care administration module. And this network's job is to continuously measure providers' gains against their value-based care contract terms and how much they could earn should they take certain action before the clock runs out, such as missed A1C appointments or the missed podiatry exams or the opportunity to bring the patient in and do a multi-purpose visit versus a single purpose visit, or missed opportunities around sending the patient engagement and education materials. There are so many terms to a value-based care model. And every day they get more and more complex as the payers who are issuing the VBCs are saying, hey, I want you to do more to engage the patient. How do you measure and track all those things that you're committing to against which you're going to end up writing a check or end up losing money? So we implemented this event-based care management system in the context of value-based care administration for doctors. A second example, in partnership with Boehringer Ingelheim, we built a diabetes care coordination network where physicians and patients who are trying to deal with a high-risk patient who has a heart condition and a risk and type 2 diabetes that is either semi-controlled or uncontrolled. How do we make sure that the patient and the family members are engaged in preventing risk of death or stroke or any other event? So this is another use of the same platform, a diabetes care coordination network. A third network we built is around the managing the risk of at home employees returning to work and the risk of exposure and the mental health and the stress issues that go with being remote and then returning to work and doing a hybrid model of work from home, work from the office. And how do they communicate safely and securely with each other? How do they assess the risk to themselves and their colleagues? And how do they communicate with HR in a secure, private manner? The fourth network that we built is a global open physician network, essentially Teladoc without boundaries. And the idea here is that physicians worldwide can engage and enroll in this network and offer services to patients worldwide based on compliance and regulatory and consent model that the patient and doctor can have. And you can create thousands of relationship models between a patient in India and a doctor in Nigeria, or a doctor in India and a patient in Nigeria. Tens of thousands of such care relationships can be individually configured, permitting a much more open network of care access. A fifth network that we are currently working on is the remote patient monitoring network around at-home care and continuous monitoring of patients who do need to be monitored and should be under the care of a physician. And we want to make sure that the physician has up-to-date information, but not just a flow of data, but actionable events on which they can actually do something and ignore the rest. So this notion of continuous data capture doesn't get you to physician interaction. The physician needs to know when it is time for them to intervene. And is it really for them to intervene, or it should be a care coordinator or a nurse or a administrative assistant stepping in? That whole notion of provider, patient, and coordinator triangle is what is this network number 5 does. And network number 6 is around behavioral and mental health management, particularly focus on suicide prevention in teens, but really going beyond that just to help patients who are, or family members largely, who are providing care to those who are troubled and are not able to make good decisions themselves. And last but not the least, a coordinated medical transportation management network, primarily built for Medicaid in mind, with the idea that instead of Medicaid vouchers, let's use a coordinated network where provider appointment, patients pickup or return location, and the state appointed care coordinator can all collaborate through a care network to use commercially available rides rather than highly expensive and limited availability of specialty rides. So getting the patient to the doctor's office, instead of issuing them a voucher, giving them a prepaid Lyft or Uber ride, is a much more efficient and less fraudulent and far more effective way to link the ride to the actual care. Now, why do I share all this with you? I want you to think about not so much what we have done, but rather these as examples of what you might do yourself. And the idea here is that if you stop thinking of healthcare as linear processes that flow left to right and have 70 steps along the way and 20 participants jump in and out of the process, that is the reason why we rely upon system interoperability as the solution to all problems. And if any of you have been involved in systems in healthcare, you know this interoperability is a utopia that we never seem to achieve. Because the more interoperability we seek, the more silos we build. So the idea here is that we need to rethink healthcare delivery fabric. The healthcare delivery fabric should not be process-centric. It should be relationship-centric. You should configure relationships and then permit certain transactions between those relationships. And that way you can decompose very long, 60-foot long printed processes into a tight triangle that you can modify either of the 3 axes easily without having to modify this long running processes. And that brings you to a much more effective tool. So now let's bring you to how that happens. So we use blockchain as a coordination fabric to achieve all this. So blockchain acts, many people think of blockchain as some kind of a cryptocurrency, Bitcoin. Yes, those are all valid use cases, but that's not what we're after. We are after using blockchain as an immutable ledger of events between any party and every other party. So using the blockchain, we can control both the identity as well as the consents that were granted, as well as events that were exchanged, as well as transactions that took place or were incomplete, as well as the ability to stamp certain data to be seen by others or not be seen by others, or interoperability, and ultimately having this immutable ledger that says, here is what happened, here is what didn't happen. And that ability becomes really transformative if you have this indisputable system of record, to use some healthcare terminology here, but it allows every participant of the ledger to maintain control and autonomy over how they participate. So I don't need to have some big, huge identity and access management database, which I control, which all of you have to trust that I know how to keep secure, and that all of you have to submit your identity into my database for you to get insured benefits from me. You can maintain your identity, and you can simply interact with me on a need-be basis, revealing as little or as much of your identity as is needed, and linking all your data, your consents, your payments, your audit, your events to that identity that you control as a patient or as a doctor. In a nutshell, we are basically trying to disintermediate the very parties that patients and doctors hate. I was a payer CIO. I remember a time when I did a road trip through my state, spoke to many physicians in town halls, meetings, in the gyms and in the city halls. And universally, I got one message from them: get out of the way. You interfere in the care with my patient. You don't facilitate or empower me or the patient. And I understood that all these well-intended programs that I was building and launching at Blue Cross for the benefit of patient or doctor wasn't going to be adopted by anyone because they didn't trust me in the role that I was. And this platform takes away that dependency of trust me, I know what I'm doing, and I have your interest in mind, and replaces that with trust no one but yourself, but collaborate with everyone that you need to. So having said that, there are very powerful mechanisms available to drive event from patient to doctor, doctor to payer, payer to patient, and keeping everybody coordinated. But think of it this way: everybody shares the ledger, everybody can read their part of the ledger, and everybody can write to the ledger what they are permitted to write to given their role, and you can build a very powerful fabric of coordination and delivery of healthcare. These are more technical diagrams. So those of you in the audience who are technically minded, we're more than happy to take your questions. I'm sharing this with you so that it can spur a new thought in your head as to how you might consider delivering healthcare for the future. Because looking backwards, we're going to find many of the root causes of why we are where we are. Looking ahead, I'm presenting you a model that gives us a way towards a much more equitable care delivery framework. Whether you're a health system or a pharmacy network or a insurer like myself, this is the platform that gives you the ability to deconstruct healthcare processes and reconstruct relationships. End of the day, one of the key core principle here is that patient and doctors control their data. The data is decentralized where there is no central database to hack for anyone. Data sharing is always between A and B, or B and C, or C and A, by consent on both sides. And all relationships can be audited visibly, but identities of who the related parties are can be kept private. But no matter what happens on the network, you can always analyze the event without having to know the identity of the event generator or the receiver, which means you can achieve an unprecedented level of compliance and audit. I'll leave you with one last thought. I was very involved in the HIPAA days. And we thought that HIPAA is going to really give the patient the power. But here is the thing. Today, the way HIPAA works, the moment you walk into a clinical setting, you sign away all your HIPAA rights. And after that, you never think about them. Because the bottom line is HIPAA rights are traded the moment you request care. Yeah, if you don't sign the HIPAA consents, you don't get care. So what do? I simply think of HIPAA as a burden, not an enabler, not in any way, shape, or form driving better care, but rather something I have to get rid of from my interaction between patient and doctor. What this kind of a system that I'm presenting to you can do is actually give the patient and the doctor the security and the autonomy they need to protect themselves and their data without having to give away those rights right at the beginning. So in the end, the idea is to build a platform on which you can build very powerful digital health networks where different parties can be defined, their roles can be defined, their relationships can be quickly defined, what events they exchange can be defined, what data they can share with each other is defined quickly. And as a result of that, you can build very powerful clinical, administrative, and financial health systems. That is a mission and vision of Solve.Care. That's what we are doing today as a company. But really the purpose today here is not to talk about Solve.Care, the company, but rather a better model of healthcare delivery. Whether you administer benefits or you do billing and payments and revenue cycle management, or you are the party doing care coordination and disease management, or you want to launch teleconsultation that goes beyond episodic care, or you want to be doing continuous data collection to do better interventions and timely interventions, or you're handling complex care or home care, or you are really advocating for patients' rights to be restored and identity and dignity to be restored to them, or you're focused on practice transformation, the fundamental question is still the same. How are we going to do things differently? And this model that I presented to you is, let's do things differently. We've been very fortunate to be regarded by many third parties as being very innovative and disruptive. And we think the real disruption here is when the patient gets better care and the provider is more effective and finds joy in practicing medicine once again. But regardless, it is nice to be recognized by the industry. But more importantly, what I want you to think about is that the healthcare problem, in one way or the other, is very similar across the planet. The reimbursement models may differ. We might be dealing with subsidized care or capitated care payment models, or we might be dealing with fully insured models, and in Canada, you might be dealing with a central payer or single authority, or you might have self-pay model for India and China. The issue isn't who reimburses whom. That's a part of the issue, but that's not the issue. The issue is how do we manage care delivery across the clinical, administrative, and financial capabilities of the healthcare system underpinning care. And that's where we are focused on. We welcome your comments. I would personally welcome any commentary or criticism or ideas you might have in how we can help you be more effective in your administrative or clinical or financial mission of delivering healthcare. And we would love to hear how we can collaborate. But end of the day, I hope that today's presentation will challenge you to think different, because healthcare of all industries requires, indeed demands, that we think things differently. Thank you for your time. I appreciate everyone listening, and I look forward to hearing from most of you with your thoughts and feedback. Have a wonderful day.
Okay, thank you, Pradeep, for this talk. It was wonderful, and it was very insightful, to be honest, to hear a different way how we can do basically healthcare, because I truly do believe that every industry has a big room for improvement and for challenging ourselves personally. Are we doing the best? So I will first start. There was I'll go in order. First question was during when you said that the healthcare institutions should be custodians, not owners of the personal data of the patients. So basically, if you can just maybe elaborate in a few sentences, what does a patient get if they are the owner, and what is the biggest change in this paradigm? Basically, I think that the people perhaps didn't understand, and I also think that this is very important message you need to send in the ether.
Well, I will answer this question in two different ways. First, I'll give you an anecdote. There was during the early 2010-11 timeframe, I was involved in many health information exchange implementations, and we built these mega highways with the idea that everybody will connect with everybody, and we will create this virtual record of care, where no matter where I go within a geographical window, let's say my state, okay, all hospitals, all pharmacies, all clinics will be coordinating and sharing data on the HIE. And therefore, we'll have this virtual care record where all of us can maintain custody of patient data, but they'll have this virtual view of all our custody data in our respective custodies. I got a big grant from the federal government. The governor appointed me to build the state HIE. We went ahead and built it, spent a couple $100 million. There was no data in the HIE. Why? Because all the custodians of data decided that it's not in their best interest to publish that data. And at that point in time, patient interest wasn't in nobody's mind. Everybody was focused on, hey, this data, if I put it there, my competitive hospital system down the road can look at it and they can analyze it, and they can do things that, or maybe the big bad Blue Cross can start interfering in my care model and they'll change my reimbursement rate. There are 1,000 things why people didn't publish the data. The bottom line is nobody did. So the patients in my state did not get any kind of a longitudinal data set that we promised them when we spent $250 million of the taxpayer money. Yeah. It wasn't lack of technology, it was the conflicting business models. So the best person who's most interested in having a longitudinal record of care and who it benefits the most is the patient. Yeah. And we have made it that almost impossible today for a patient to reconstruct their care. Anything beyond 30, 60, 90 days, forget it. You don't even remember where your data is sitting, let alone assemble it. So if we are being truly honest with ourselves, we have the right to a copy of the data that is related to the episode of care we managed as a hospital system or as a care provider. but neither we nor the patient has a longitudinal view. And if anybody's going to have that view, it should be patient, because it's their health data. So if you talk about portability, if you talk about effective care, if you talk about optimal outcomes, somebody needs to have that data view, and nobody better than the patient to have that data. Because interoperability and portability of data is the right of the patient, not us as the custodians of data. We need to have custody of data for business rights, for legal rights, for protecting our care model, for our care, for defending our care delivery. Yes, but that's a block in the chain, not the whole chain. Because even if you seek it, you're not going to get it. And the moment we seek to build this chain privately, we actually fail at it from the day one. Mission impossible. The only possible mission here is for the patient to have the chain and for us to have the block. And that's where we come from. The second is that for us to do any kind of a true care delivery across a time frame where we talk about cradle to grave care, we talk about patient-centered medical home, all of these things are ultimately relying upon us having relevant information. And here's the funny thing, the EMR tells me that I have prescribed 4 medications to my patient, but I actually don't know what they're taking. The only true source of information is what the patient actually tells me when I see them 90 days apart during their check-in visits. So who actually is the real source of data here for the most part? Yes, I am as a clinical care provider, but so is the patient, and they have a better, more complete view. So those are the 2 reasons why I've long believed that while every care provider has right to their version of the block, the only person who can actually own the chain is the patient. And if you're ever going to have a longitudinal view of information used solely for the purpose of the patient, let's put the chain in the hands of the patient.
Yeah, I can relate to that. We'll have tomorrow one of the things that's engaging patients in the basically that's the latest concept that is proving to have the most impact. Basically is to engaging patient in the diagnostic process, to also understand their data and to also monitor the data, because they are like you said, that's the premises behind it, that philosophy that the person in charge of his own or her own body is the one who knows the best what is happening. Maybe not all the time he can explain, but he can give the good feedback and good let's say small signs to the practitioners of healthcare in the healthcare industry. So being said that, the second question is, and I will also just take 1 minute also to emphasize one thing, and I would like to hear your is why did you choose diabetes as one of the primary things? I would just like to add that I have a personal experience also with my girlfriend. She's a diabetic, and most of the persons who are not know anyone who has this problem doesn't understand how big this problem is, and how it can create a lot of very strange situation in life. And it is very important to talk about it. And there is a lot of people with diabetes, but you just think, okay, that everything is normal. So the question is, how and why did you choose diabetes in one of the primary networks in your company?
So look, every chronic disease destroys human life and human value in ways that is hard to comprehend unless you experience it yourself. And most of us at some point or the other will have a chronic disease to contend with. Diabetes has some unique properties. Number one property is prevalence, right? This is one of the most prevalent diseases out there. And it has such a outsized impact on you, on your lifestyle, on your life, and your ability as a human being to function. But in terms of number scale, it's massive global issue. It's not just a first world or a second world or a third world problem. You have a preponderance of diabetics in the US because of our lifestyle and eating habits, but you have a preponderance of diabetics in India. You have a preponderance of diabetics in the Middle East. So it's a global phenomenon. It's a global negative phenomenon that impacts almost every one of us. I mean, personally, my father, I lost him to diabetes and diabetes-related complications that probably played a role. But in the end, we are focused on any and all chronic disease management. Now, we are fortunate to have partnered with Boehringer Ingelheim, which has a huge commitment to improving diabetes care coordination and to improving patient education and engagement and to improving physicians' ability to deal with diabetes and its complexities. So, it's one of those causes where we can all unite behind. And then we had a very strong commitment from Boehringer Ingelheim to build this network where it was with the patient in mind at all times. So philosophically, we aligned with them. And I think the third reason is diabetes impacts so much. It creates such a complex impact on your body. It's not just about your blood sugar, what it does to your organs, your eyes, your feet, your memory, your ability to function. It has an outsized impact. So you need a team. It's a coordination problem. And you need to continuously adapt the situation to the right participants in the team. So it's a continuously evolving team problem. And we figured that if we can crack that nut, we can crack almost every other nut.
Okay, this sounds very interesting. We have one additional question regarding your network and two regarding the structure. So I think that this all, if something is come across, I will also read it. But first one is related the prevention, prevention regarding the mental issues and mental issues. So basically, the question is how much more stress the network was during COVID-19, and basically, do you have any kind of data if it's different between the ages, different groups of ages, like basically between the minors, between, I don't know, minors not using your network, but the young people, young adults, somebody who is like middle age or old age. So do you have any kind of data how they are the different approach toward this mental issue problem, which is also, I think, very important to stress about?
That's a very insightful question. It's obviously from someone who thinks about mental health impact on society. Because what we found as we are working with various organizations is that there has been an outsized impact on young adults and pre-adult teens more than adults. We have all had enormous stress from what COVID did to, there's a world before COVID and a world after COVID, and we're still adjusting to this and probably will adjust for a decade to come. But for children, for young teens and young adults, it has been outsized impact because they haven't had the faculty to adjust to this suddenly different world. We are focused on today working with a very powerful, very compelling group out of India who focuses on teen suicides. And so it's young adults who are not able to cope with the pressure of society, education, their career, and then COVID layered on a huge stress. And what we have heard from them and what the data they have shared with us, and we are more than happy to share that data with those who wish to see it, that the impact and the fatal self-harm has gone up by order of 4 to 5x, meaning the number of suicides per 10,000 young adults is gone up, a significant multiplier, not a few percentages. So we were compelled by that. We felt that if there was a timely and safe interaction between the child or the teenager or the young adult in stress with a safe pair of ears who could hear and counsel, and if you could protect the identity of both sides, we did not ask them to reveal their location or their any information they don't want to reveal, but to allow them to be referred without having any revelation they don't wish to make, or to escalate the case, essentially to de-identify the individual, but still run a full care model around them. That was the two intersecting curves. We're going to have to protect the identity for as long as we can till they get to the point where they're willing to reveal the identity from a care perspective, but still run a complete care model that can prevent or delay a suicidal action. So it's a very important but difficult balance, if you will. But it is achievable and it is getting achieved. So this is not outside the realm of thinking about what kind of a relationship do you want to allow between the initial contact or the psychologist or the psychiatrist, and how do you give the subject, the patient, a sense of control, which is very important for them. So those are the kind of philosophical point of view that align with our platform's philosophy. So it was a good fit. But we have only scratched the surface. I think there is so much that can be done there, but we are just starting to get into that space.
In one moment, I would like to connect you with representatives of InfoBit, which is unicorn from Europe, Western Balkan, which are doing the messaging system, and one of their future projects they would like to come is that basically creating a model also who is going to help the people with mental issues. So basically, I think that possibly cooperation, just talking about possible cooperation between these two big companies, yours and Infobip, I think that can lead to something really great, basically. So I will take let's say I will do this connection after the conference is finished. I think that this can be a good fit. Like it can be we will see. Nothing promising, but it maybe can be solid because they have one additional insights, right, regarding messaging and how to do NLP and ML. So it can be a cool joint venture. But I will do that after conference. Regarding to last question, they are a little bit more technical question. So basically, one question is regarding regarding data security, and it was like, how does it anonymization between data is working between the different layers in the ledger? So basically, it was like the question was if what is the secure point when we are sure that there is no like anybody, the third party source is not having the data because they're on the ledger. So and how we are and also how do we secure that we are not providing to the wrong person data, like we just because we don't understand the field how to operate with the technology. So did you have this kind of things thinking about in your, I suppose yes, but I will let you to answer.
That's a great question. I must admit that I'm a data scientist by education, and I'll probably always be a data scientist and a data architect no matter what role I play. So these are very important. This is a very fundamentally important question. And in healthcare, I think you have to decompose every transaction between two parties into at least a very well-defined data layers, if you will. And those of you who are data architects will know what I'm talking about. But generally speaking, if you think in layman's terms, let's say that I interact with my doctor and I want to simply make a request to come see the doctor tomorrow. There is certain identity information that I have, such as who I am, what my, do I have an existing provider relationship with that provider, patient-provider relationship with this doctor, or is it a new one? Do I have existing consents in place? Do I have an insurance plan? Do I have a copay co-insurance and whatever? So there is a certain, these are different data elements. And there is, of course, clinical data on, am I currently on medication? Do I have certain disease conditions? What are my current symptoms or issues I'm reporting? There's a clinical side. And a third is around, what other, care history do I have that is relevant to this particular episode? So you have identity data, you have transaction parameters, you have financial and reimbursement questions, and you have the clinical parameters, right? Those are at least very basic building blocks of any healthcare transaction. So what you can do and you should do in each relationship, whether it's AB or BC or CA relationship, you can put these data points in different places. So for example, the identity of the patient in our system, and you can design similar systems without, with slightly different variations. The general construct is that there is a identity box, in our case, the care wallet, where the patient identity or the doctor identity resides. And that identity is only shared to the degrees necessary for the transaction to flow. So if I want to make a request for an appointment, I only need to reveal the fact that I'm insured with Blue Cross Blue Shield, I have a valid policy, and I am an existing patient, and that should be enough for me to get through most of the transaction. Versus if I'm requesting an online teleconsult, the amount of data I'm going to share is different. So the point here is that you can manage this data security the following. First is decompose the data into its various intrinsic properties, then see if that data needs to be linked to the event, or is that data that is not linked to the event. If it's not linked to the event, you don't share it. Third is attach consents to both sides, one's issuing side and the receiving side. The issuer is essentially sending the data with the consent for the other party to receive it. And the fourth is encrypted. So the way in our system things work is when party A sends a health event to party B, could be a clinical event, could be an administrative event, could be a financial event, the party A stamps that event on the chain, thereby agreeing, digitally signing that event to say, I am agreeing to send this event to Alex, okay? Now, the content of that event is gonna, of course, be definable based on the event's needs. You don't need to know the name of my dog to check certain attributes about this event. Only event-specific payload crosses over to the other side. The Alex, when he receives that event, has received a key from me as part of that signature. saying you can read this event and you can see what the data attached to it is. But you can deny forwarding capability. You can say, look, if this event is forwarded to somebody else, the key will be invalid.
Yeah.
So there are some very sophisticated ways, particularly if you use cryptography like blockchain does, and you do data tiering and you link the data to an event to a relationship, and relationship to two parties, you can control everything. You can literally control every healthcare transaction, and you can meet and exceed the intent of HIPAA or GDPR or high-tech, because those laws were written with a core principle that the data, that there is a party who benefits and should control the use of their information. And there's a party who needs that data to deliver value to party A. And that intent is impossible to do in current centralized databases, because the moment you give data to somebody, it becomes theirs, in their custody. In our system, and system like ours, you can actually share data without giving up ownership of it. You can define its purpose, its forwardability, and its duration. You can even expire the key after 30 days and say, look, after 30 days, this key is no longer valid and you can't open that record again. Yeah. So much more granular control over data is needed, merited, and we've been working on it for years and will continue to enhance that data management capability.
Okay, this is very insightful. Thank you. And this is like awesome. Awesome. I think the perfect opportunity to talk about it, because it's not only about the Solve.Care as application, but also like about the philosophy behind it, because people do tend to forget that in the end also programming and architecture is also about putting your philosophy inside of it, and your view of how technology should be used. But people do tend to forget this. We have two questions. One question additionally I get from directly from Cleveland as well. First one is regarding the in one part you were talking about the communication between the different stakeholders and involving patients. So the question was, does this mean that the patient will be overwhelmed with the notifications, because like to read it correctly, there is too much notifications right now. One more notification, not something that is possibly needed. So basically, if you can just give us an overview, what does this standpoint from a view of the user, basically of the patient, how does this work?
It's a brilliant question, and the answer is, of course, the last thing you and I need is another pop-up text message on your device. So there is a difference between the wallet and the node. So I will try to explain this. So when interaction happens between a physician and a patient, or patient and a pharmacy, or a pharmacy and a pair, or whatever the A and B parties, A, B, C, D parties are, doesn't really matter. Each of them has a node, and the node is where you define event handlers. So your objective as a network designer is not to just propagate every event that you receive up to the wallet of the individual, the human being. Your job is to have 99% of these events handled automatically or through the event handlers on your node. Let me give you an example. In our system, if you're a physician, one of the implementations, there are many variations, but in the global telehealth exchange, a physician can publish their availability. That does not go into a centralized database. It's on their own node. When a patient in Bangladesh wants to see a pediatrician, they put a request on the chain. That request is picked up by pediatric networks who have a signature of pediatrician. Those nodes then individually process and evaluate the request against the availability and provide a response in real time saying, yes, the physician has availability between 3:15 and 3:45 a.m. this morning. And is actually agreeing to accept patients in that window of time. I'm giving you an extreme example here. And the node will respond to that event without the physician wallet being notified. There's nothing yet to be done. Only when the patient makes an appointment and pays for it, does that slot get booked on the node. The node sends a secure digital token to the other side saying, I have confirmed your appointment. Here's your token handle. This is how you can open a teleconsultation session with me when the time comes. And the token will activate at 3:44 or 3 or 4 a.m. when your call is scheduled to begin. You can do all kinds of wonderful things there. So the idea here is that the physician does not need to be notified of any event that took place at the node level until and unless a transaction has consummated, in which case you do. So there's a big difference between handling events and propagating events to the human being. And our vision, my vision, has always been majority of healthcare transactions do not require either the patient or the doctor to be online and interacting with each other. We can do most of the work at their digital identity level, because each individual's digital identity is in their node, and their node is evergreen. While I'm sleeping, my node is working. So in many ways, we are flipping the idea of my database, my system, my Epic, my Cerner, everybody connect to it and do whatever you need to do it. And I'll tell you when it's up and I'll tell you when it's down. And I'll tell you who can see what, to you all have your mini computers essentially in the cloud. And your space, your compute space, your data space, your identity space, and your business logic space is in your control, but you don't need to be awake for that space to be active, right? So the decentralized compute model that we have allows physician to not be notified of most anything. Because frankly, the last thing we need to do is to tell the doc how we're handling all the administrative stuff. All the doc needs to know is, what is my schedule tomorrow morning? When I wake up, I see my schedule, I know I have 62 appointments, I'm good to go.
Yeah, that's right. I totally agree on that. Okay, the last question is from the Cleveland. So could we provide assistance for those who have comprehension issues when it comes to the transition healthcare data, tracking for their health improvements and what they are to do?
If I understand the question, I didn't fully follow it. You're speaking about.
Just read it again.
Could you please? Yes.
Could we provide assistance for those who have comprehension issues when it comes to the transition healthcare data, tracking for their health improvements and what they are to do?
Great question. So if we are talking about an impaired patient ability to take care of themselves, be it mental health, Alzheimer's or Parkinson's, if we're talking about physical immobility, or they are in an institution or they are hospitalized, you can clearly create we have this notion of care circle, and the care circle is essentially people that the patient has invited to represent them, either purely from a mental support perspective or from a financial support perspective or from a delegated authority perspective. So a care circle is something that a patient can create and delegate certain authority to them, either proactively or situationally. So in that regard, reduced comprehension or literacy problems or dexterity problems or whatever you might have, and you will have all of those combinations, you can delegate that authority to a different care wallet who can then act on your behalf. But they can only act on your behalf for as long as you wish, and you can revoke that consent, and they will then be removed from your ability to access your node. So there is certain degree of thought process that goes into architecture of a platform like ours, where you have to think about delegated authority. You have to think about the ability for someone to assume authority, even if they didn't have the delegated authority, because there is no other alternative. For instance, a trauma case where the patient is brought in with no ability to communicate. How do we assume the role of a guardian or a caretaker till such time when a truly authorized person can show up or not? So delegation of authority is done through the wallet. Same is true with comprehension or mobility or dexterity issues and restraints. But it's an imperfect solution. I do not want you to think that technology will fix this 100%, because there will be law, there will be governance issues, there's ethical issues involved in how and when authority should be assumed when it has not been explicitly granted. So the idea is to permit all those variations and those societally important things to be configured in a relationship. But I'll tell you, the way we would configure a power of attorney or a authority to a third party in US would not fly in India. So India, the delegated relationship model is going to be different. It's not because law is different, but human expectations are different. So I think those kind of things, the level of privacy that a patient is comfortable with, or lack of privacy a patient is comfortable with in a family-oriented model of care coordination, such as Asia tends to be, would not fly in the US either. So it takes me back to my original point. Relationship management is not just a technological goal, it's also a human goal in enabling the patient-doctor, patient-family member relationships to actually function in a way that healthcare can be delivered effectively. And they are gonna be different for the same signature. Your patient-doctor relationship or patient-family member relationship and the level of authority you wanna delegate in the G20 is probably different than you're gonna delegate in the developing nation. So we have thought about it in the context of enabling relationships to be configured, but we have not mandated what relationship makes the most sense. But that's a very local thing like religion and politics. You got to configure healthcare to the needs of the population.
Okay. Pradeep, thank you. Didn't have any more question. I think that this was like the talk for itself was the answering to the question. So because I like to have when we are having this kind of discussion after the talk as well, because that means that the talk has bounced good among the public. So basically, what I want to